Hi, everyone. My name is Millie Das. I'm a thoracic medical oncologist at Stanford University and at the VA in Palo Alto. And I'd like to welcome you all here today to Lung Cancers Today, where I'm joined here today by colleagues to discuss non-small cell lung cancer with a focus on metastatic disease and new ASCO 2024 data. I'll allow my colleagues to introduce themselves.
Kent Shih, I'm a medical oncologist based in Nashville, Tennessee with Tennessee Oncology, part of Oncology.
I'm Martin Dietrich. I'm a medical oncologist at US Oncology in Orlando, Florida.
I'm Ticiana Leal. I'm an associate professor and director of the thoracic oncology program at the Winship Cancer Institute of Emory University in Atlanta, Georgia. Thanks for the invite.
So we're going to start with just talking about an overview of non-small cell lung cancer. And I'd love for us to just speak a little bit to our experiences on how we think about our patients with metastatic lung cancer, how these patients are typically diagnosed and getting to you in your clinics, and perhaps also speaking a little bit to the unmet needs in these patients. And so I'll start with you, Ken.
Yeah, I mean, there's a lot of lung cancer where I'm from in the South, and so, early detection and early diagnosis I think is very important. They're funneled into our multidisciplinary team, as I'm sure they are with you guys, and we kind of manage each patient individually. But increasingly, particularly in the community, I think it's becoming more complex and more difficult as data rolls in.
Martin, similar.
Well, we have a very low rate, unfortunately, in Central Florida of lung cancer screening. We're still improving. Obviously, those would have been interventions for us to detect disease earlier, to have a better chance for a better outcome. So we're still working on implementing this on a broader scale, raising awareness in the at-risk community to actually implement lung cancer screening.
Yeah, similar experience. I think, rates of lung cancer screening are still below what they should be. And so although I have had patients in my clinic with lung cancer diagnosed with low-dose CT scans, those are low number of patients still. So I would say that more than half of the patients in my clinic still have either locally advanced disease or advanced disease. So certainly these are patients that a lot of them come in with a lot of symptoms, and there could be a lot of issues with just the time that it takes to still get to that initial treatment discussion. A lot of times we're still talking about, at that initial discussion, we need to do NGS. We don't have reflex testing yet. So doing NGS, managing symptoms, completing the staging workup many times, and then certainly, trying to get patients on the right treatment as quickly as possible and addressing all of their needs takes a village. So we work with a multi-D team, and that is, I think, essential part of lung cancer care.
Absolutely. I think that we're all excited about the data that supports lung cancer screening. I think we can all agree that we're not doing a very good job on a national level, and unfortunately the majority of our patients are still presenting with metastatic disease, and it does become a challenge. So on the topic of NGS testing, I wanted to ask each of you at your various institutions, how does NGS testing happen? So does it happen reflexively? Ticiana, you mentioned it's not happening reflexively. Right. So if you're having to order it as a medical oncologist, what's the turnaround time? Are you using those results to help inform treatment decisions?
Yeah, NGS testing, now that we have targeted therapy in early stage lung cancer, we just heard the LAURA trial today where we're going to be using targeted therapy in stage 3 non-small cell lung cancer. So we are doing NGS. We do broad NGS panels, both in tissue as well as in plasma. But it really is something that is ordered by medical oncology. We have it integrated into Epic, which has facilitated ordering for sure. And certainly I think a lot of our multi-D team members will order NGS testing, but it's not their primary role. So it still is, primarily medical oncology requesting all those tests. We do have something that has been very helpful, which is we have a diagnostic clinic. So we have a diagnostic clinic where patients come in and they clearly have a diagnosis of cancer, but not yet diagnosed. And so we're doing the workup in this initial diagnostic clinic. And I have found that very helpful because then the diagnostic clinic will just start the NGS testing. Okay. So by the time they hit our clinic, hopefully we have results or very close to getting results for NGS testing. Turnaround time for plasma, it's the usual 7 to 10 days, and then turnaround time for the tissue-based testing tends to be 2 to 3 weeks.
Martin?
Yeah, a similar experience. It's mainly upon us to order tissue testing. Unfortunately, our turnaround times are closer to 3 weeks, not as fast, unfortunately. Depending on where the biopsy was taken, this may be a delay. That's why we include routinely now liquid-based approaches as well to accelerate time to treatment. Many of the actionable alterations are detected very sensitively on biopsies from plasma. So I think those are combined approaches that help us facilitate some of those time to treatment concerns that we have with patients, especially symptomatic patients that oftentimes have a higher circulating tumor DNA fraction. So, but it's upon us, and unfortunately, the speed is a main issue. Now that we have it approved in all stages, I think it's a good time to start thinking about reflex protocols in pathology.
So, yeah, it's kind of an interesting story. We do reflex testing now. I fought that battle 5 or 10 years ago where we didn't, and sort of hit my head against the wall several times until I gave up because of cost, which is what I was told. And then several years ago, they just did a 180 and decided to reflex test everybody, squamous, non-squamous, 1A to 4. And so that has its pros and cons, right? So I get information earlier. At the same time, I also run out of tissue to submit for the 8 slides, 16 slides that's necessary for protocols, right? And so there's always a yin and yang, pros and cons to getting reflex testing. And also, it may be an EBIS FNA where we get a nip of tissue just enough for diagnosis, but not quite enough for everything. So then that falls to me to do the serum testing, which then delays things. But in all, our hospital that I'm at is small and nimble enough to where most, if not all, early stage cases get presented in multi-D conference, and so we can kind of work out what needs to be done prior to them seeing me officially.
Yeah, I think it's. I had a similar experience where reflex testing was not being done, and as of a few years ago, it is now being routinely ordered by the interventionalists who are performing the biopsies, which is really great. So by the time the patients do come to us, we do have those results. Every now and then, you'll find an instance where a patient didn't have it done for whatever reason, and I do find that you're already kind of behind the ball when you're having to order it.